Thank you so much for inviting me to present this data. So this systematic review was commissioned by WHO to support the HBV guidelines published last year. I don't need to do any background because everyone in this room knows a lot about this. The key problem statement I'd like us to absorb that we're trying to consider and try and look for solutions in this systematic review is that we have only diagnosed an estimated 4% of individuals living with hepatitis B. So in Africa, that means only 2 million out of 64 million that we've actually diagnosed. So it's an incredible burden of disease out there that's undiagnosed, no treatment eligibility assessment, and no access to antiviral therapy. So we've got to think hard about how are we going to close that gap. At the moment, that represents a huge missed opportunity to prevent liver-related death in HCC. So what can we do? So this systematic review follows from a previous review for hepatitis C published a few years ago, which identified 142 studies in the field of hepatitis C and identified, largely through observational evidence, that decentralization, same-day test and treat, integration with non-specialist services and task sharing were associated with enhanced outcomes. And in the hepatitis C world, that's SVR. For HIV, there's an enormous wealth of evidence. So a systematic review published in Lancet HIV back in 2017 identified 85 randomized control trials, including a total of 16,000 participants, which showed evidence for the clinical effectiveness, and the outcomes there are patient retention and viral load suppression. For peer support, counselors, text message reminders, adherence clubs, psychological support. So HIV has got an enormous wealth of evidence for how to make patients stay in care and achieve virologic suppression. So the questions here are, what about hepatitis B? What are our outcomes in terms of all the published literature? And which approaches in terms of service delivery have been associated with the best care outcomes? Is there anything we can learn from what's already out there in the literature? And when we think about the care cascade, I think it's a concept that's probably familiar to almost all of us. And it's this concept that you must progress through each stage to progress to the next step. So it's a cumulative concept. So the first step is diagnosis, of course. But this review is focused on what happens next. So I'm HBsAg positive, now what? So the next step is eligibility assessment, which is obviously something unique to hepatitis B. We have to understand now with the WHO guidelines, it's half of patients that will need treatment and half that won't, but it used to be 20-80 split. So once we're identified that the patient's eligible, then who starts treatment, who actually goes on to antiviral therapy? And then once patients are on treatment or deferred for monitoring because they're not eligible, how many of those are retained in care and come back to care after a year, after 18 months? And finally, how many patients attain virologic suppression? So it's not really one meta-analysis, it's more like, I don't know how many of those you count up, 6 or 7 of them. But so we identified evidence from the last 10 years with quite broad search terms. And this is the publication. It's online, so if you want to have a look at the full text, it's on the Lancet GastroHep website. So the contributors, colleagues from Rishikesh in India, from Vietnam, Philippines, from Harvard, and Jibril from the Gambia, and Roger Chu from Ohio State University, and Prof. Easterbrook. And this are, you probably can't see that unless you've got exceptionally good eyesight, but we went through 4,800 studies, and in the end 106 were eligible for inclusion. And we included studies that reported what kind of service delivery model was being offered and what their outcomes were. And we excluded non-generalizable criteria such as a requirement only patients with cirrhosis or only patients who've had a certain duration of therapy. Excluded studies that used old treatment or investigative treatment or those that were switch or stop studies. We pooled estimates for proportions using a generalized linear mixed model with a logic link with study random effects. To pool a proportion of those achieving that objective at that step in the care cascade. And we pooled intra-study comparisons for things like a comparison of those within a study who are on antiviral therapy versus not, for example. So these are the included studies. What you can see on the x-axis is when the study was published. And I think it's quite clear that most of the publications have really come in the last few years, which is fantastic, because it shows that this is really an area of emerging interest. The one on the right shows the country income classification. So 41% of studies are from low and middle income countries. And in terms of the WHO region, you can see there was a good geographic distribution from all global regions, apart from probably Southeast Asia. And this map just shows the location of the studies. Most were the dark red hospital-based specialist care studies, and there's a mixture of other models. Some of the yellow ones were primary care, community test and treat models, and then we also looked at models that involved integration with other services like HIV, prison care, harm reduction services. This plot here on the left just shows not when it was published, but when the study was conducted. So quite a few retrospective cohort studies that have gone back many years, but again, there's been much more interest in recent years. And then on the right-hand side, you can just see the different models of care across the years of publication. This just gives you an illustration of the included cohorts. So most of our evidence comes from observational studies. There's only 7 RCTs, and about 20% were interventional, non-randomized, single-arm studies. Of those 7 RCTs, 6 of them were not relating to models of service delivery, so there were elements like comparing tenofovir and entecavir, etc. And only 1 randomized trial exists so far that actually evaluates a service delivery model. And that study was assessing in the United Kingdom primary care, whether to decentralize care close to the patient or hospital-based, and that was actually a negative result. The outcomes were better in the hospital. So this figure shows you which elements of the care cascade were reported. So each row is a study. The study types are grouped together. So at the top is hospital-based, co-managed, primary care, etc., going down. And across the x-axis from left to right is the different elements of the care cascade. So what you notice there, blue, is that the element was reported by the study, and purple was it was not. What you can see there is eligibility assessment and starting on antiviral therapy are elements that are well reported. Lots of cohort studies have presented data on that. But crucially, the longitudinal outcomes like retention and care, do we get the patients back to the clinic after a year, after 2 years? And whether patients virologically suppress, very, very few studies are reporting on these longitudinal outcomes. And that just reflects the fact that it's obviously much more difficult to do so, to measure longitudinally over time. But that's a real lacuna in terms of the available evidence basis. So I just grouped the outcomes, like thematically. We observed an attrition among the hospital-based specialist care, if we take that as our benchmark, of about 15 to 25% attrition at each step of the care cascade. So that's really considerable, and obviously it accumulates over time. Retention care was significantly worse among patients who were not treated with antiviral therapy, and we assessed that association in 2 ways. One was we pooled data from all the centres that reported for patients on antiviral therapy, and similarly pooled data from all centres that reported not on antiviral therapy. So that's an indirect comparison. And then secondly, we did a direct comparison of an intra-study evaluation of patients that were and were not treated with antiviral therapy. And the results from both of those different ways of analysing the question were consistent. They showed significantly worse retention and care in patients that did not receive treatment with antiviral therapy. So this is the care cascade going from left to right. You can see the purple bar. The left-hand side, which is panel A, is hospital-based specialist care for patients who are on antiviral therapy. You can see about a quarter of patients diagnosed with hepatitis B, and this is a pooled estimate from 20 different studies. About a quarter did not have a treatment eligibility assessment following their diagnosis. And then of those eligible, a further 22% did not start antiviral therapy if they were eligible to start. 12% of those patients started on ART were lost to follow-up at a median duration of 12 months. And then finally, those who retained in care, 27% did not achieve virologic suppression at 12 months. So when you accumulate all of those cascade steps and combine the attrition estimates, you're left with 37% of those starting off with an HBsAg positive diagnosis finally achieving virologic suppression. So we've definitely got our work cut out for us, haven't we? It's not very good. And then on the right-hand side is patients who are not treated with antiviral therapy. And there you can see, as I said previously, the attrition was much higher, albeit with greater uncertainty, so evidence only from 2 studies there. But approximately half of patients not started on therapy are lost to follow-up. So that's a really significant attrition. And then I said that intra-study comparison. So this is pooling risk ratios, comparing patients who are on antiviral therapy and not on antiviral therapy. And you can see that firstly, it's consistent across all studies, a similar effect size, that there's consistently greater retention in care across 5 studies there, from mostly from European countries, but one from Sierra Leone there, showing greater retention in patients that we start on antiviral therapy. And the pooled estimate there is 1.72, so that's a really significant effect size in terms of the association with better retention. And then more key findings from this. Outcomes were observed to be inferior in primary care settings or co-managed, where a specialist and primary care managed together, as compared with specialist care. And patient-borne costs, for example, in centres like in Romania and a study from Ghana, where patients had to pay for their own diagnostics, were associated with poorer outcomes across the care cascade, as we would all expect. And then finally, we did see some really promising models for community-based testing, which was linked to a dedicated research clinic. But long-term outcome data from those models of care are lacking. But at least insofar as getting a treatment eligibility assessment done, getting patients onto treatment, they do better than many of the other models. So here's some of the other models there. You can see that there's only data for the upfront parts of the care cascade for these models. But community screening and treat, linkage to a dedicated research clinic, there's better outcomes in terms of lower rates of attrition, in terms of getting treatment eligibility assessment done, and starting antiviral therapy when eligible. So that's promising. We just now need to get some longitudinal outcome data. Co-managed, we see a significant increase in attrition at both of those key steps, and primary care was the worst. So about 50% of patients not having an eligibility assessment done at primary care, and 50% of those eligible not starting on therapy. So I think this just highlights for us that probably our guidelines have been too complex for non-specialists to understand and implement in practice, and to really get that decentralization, which we're going to need to achieve to close that gap of patients. We're going to have to invest in primary care, and we're going to have to do more training and assist our colleagues. So if I compare side by side with HIV, so I do HIV as my other job, there for HIV, we're used to sort of seeing figures of 10 to 15% drop off at each step of their care cascade, in terms of getting onto AVT and suppressing. So it's much worse in terms of the pooled estimates from all of the available data that we could find for hepatitis B. So what do we find? What's associated then in terms of care models with poor outcomes? So as I said before, primary care, post-pregnancy care. So there was consistent effect size. About half of patients who were diagnosed during pregnancy were finally linked to care post-pregnancy for their own health. So that's a really big area that we need to work on. Self-directed care, that is initiatives where they go and do community screening, diagnose patients in the community, but then say, here's your hepatitis B positive result, go and find care for yourself. There's associated with a really high rate of drop-off. So in some studies, only 25% of those individuals subsequently were linked to care. So that's a really big problem. Interestingly, there was no effect seen when we compare high-income countries versus low and middle-income countries. So we're doing universally pretty badly across all settings in terms of hepatitis B, and that's assessed by a meta-regression analysis. So what does work then? Let's not be too negative. Community screen and treat looks promising. Now we need long-term outcome data. Reflex assessment, same-day initiation decisions. For some models, there is evidence that patient navigators trying to help people through the care system and link them to care, and support for transport and travel treatment costs seems to be associated with improved outcomes. So let's conclude. We have a problem. We're achieving low rates of treatment evaluation. We're missing out lots of patients in terms of getting them on treatment when they need, and we're not doing very well in terms of retention and care. And if we benchmark ourselves against HIV, we've got a long way to go. So what do we need to do? We need operational, interventional, and innovative research to try and help us understand how to do better. So there's obviously lots of literature from HIV which we can borrow and we can adopt to HIV, but there's some promising and emerging models. But we need some randomized implementation research. So thank you very much for your attention.